We're not ready.
Okay, we're live, Madam Chair.
I'm sorry?
We're live, Madam Chair.
Super, very good. Well then, welcome everybody to Joint Labor, Health and Social Services. It's October 6th. Tomorrow will be the 7th. We're in Cheyenne, Wyoming, and we have a nice agenda of useful topics. And if you would call the roll, please.
Madam Chair, this is roll call for the Joint Labor, Health and Social Services Committee. Senator Furphy.
Here.
Senator Hutchings.
Excused, although she looked for a Zoom request from her.
Senator McEwen.
Excused, but likewise look for a request from him.
Senator Wasberger.
Excused.
Representative Brown.
Here.
Representative Connolly.
Here.
Representative Flitner.
Excused.
Representative Hallinan.
Here.
Representative LeBeau.
Here.
Representative Ottman. Representative Stivar. Representative Worf.
Absent.
Co-Chairman Baldwin.
Here.
Madam Chair Wilson.
Here.
Madam Chair, you have a quorum.
How many spare do we have?
Madam Chair, this is Senator McEwen. I'm present also.
Good, glad to hear you.
And Senator Hutchings is here.
Excellent,
Madam Chairman, this is Representative Flitner.
excellent, very good. Now I don't have to worry about when people go to the bathroom. Okay, the first item on our list is Department of Workforce Services statutory updates. Mr. Wolf, I see, are you here for Director? Then come on up. Remember how to chair, kind of spaced it.
Good morning. I am Liz Gagan, the Deputy Director of the Department of Workforce Services, as Director Cooley was unable to make it this morning. And I would like to introduce Jason Wolf, who is the administrator who oversees the Workers' Compensation Division, who's probably well known to you. And he will talk about potential revisions to Wyoming Statute 27-14-108. Thank you.
Mr. Wolf.
Madam Chairman, Jason Wolf with the Department of Workforce Services, here today to talk to you regarding Statute 27-14-108. This is what we refer to as our coverage statute for workers' compensation. The industry codes enumerated within the statute are the industries which we term extra hazardous and therefore are required to have coverage under the Wyoming Workers' Comp Fund. As you probably saw our introductory letter, we follow what by statute, we follow the NAICS manual, which is the North American Industry Classification System. And that manual is updated on a 5-year basis. And this year we did have about 4 different sectors that were affected with the changes. And what we submitted to you was just to keep pace with that NAICS manual and update the subsectors as correspond with the NAICS manual. With that, Madam Chairman, I think maybe just kind of walk through the bill just a bit.
Yeah, that'd be good.
Starting on page 2.
Madam Chair,
Senator Hutchings.
thank you. And I really hate to interrupt, but there were a couple questions that I had before we get started on the bill. Maybe some of you who have been on the committee for years know the NAICS codes, the North American classification system that you have here. Can you tell us, when you say North American, what does that include? Does it include Canada?
Madam Chairman, Senator Hutchings, that's correct. The North American classification system encompasses, of course, the United States, Canada, and Mexico.
Great. Okay. And who are these people that make up this particular code, these codes? And the reason why I'm asking is because when I look through the bill and in your letter, these codes are classified as extra hazardous industries. And when I look at wholesale trade, farming, beer and wine, miscellaneous durable goods, how are we classifying those as extra hazardous?
Mr. Wolf?
Madam Chairman, Senator Hutchings, the manual itself does not term the industries extra hazardous. I guess to answer your question, the NAICS system is a offshoot of the Census Bureau. You can find them at the censusbureau.gov. That's where the manual is posted. That's where we get this. I believe over the years, the legislature is the body that determined which industries are in fact extra hazardous and therefore are required to have coverage. The manual itself does not do that.
Okay, thank you.
All right, go ahead, Mr. Wolf, thank you.
Okay, Madam Chairman, on page 2, starting on line 11, wholesale trade is one of the sectors that was affected with the change. You'll see on line 13, we want to change subsector 422 to now is subsector 424. And then those sectors down below from lines 16 through 23 are also encompassed in the wholesale trade sector. And also moving over to page 3 of the bill, line 2 through 5, those are also some changes that are encompassed in the wholesale trade sector. Moving down to page 3, line 16, we start with a retail trade sector. The line 17 is the one change on there. And I would note, just as we're going through here, the way we determine the coverage is the specific industry codes that are enumerated within the statute are the ones that we cover. And so when we get onto the next page, I'll kind of explain the staff comments that are in there. So going on to page 4, again, the retail trade encompasses a lot of stuff. These are the specific industries that we cover under the retail trade. The meat markets and the seafood markets, which the staff comments within there state that they now, in the NAICS manual, use the term retailer instead of markets. We would be fine with that change if you guys choose to make that, just to keep pace with the manual. Page 4, line 19 starts subsector 457 is the new subsector, gasoline stations and fuel dealers. When we submitted this, you'll see on lines 22 through 26 on page 4, and going over to page 5, starting on line 12, we included a breakdown of fuel dealers. I believe, the staff comment here on at the top of page 5, the committee may wish to consider if it's necessary to add the NAICS industry 45712, which is other gasoline stations. In further looking at the manual, my recommendation would just be to leave it at subsector 457. What that means to us within the division is that any NAICS code that falls under that subsector 457 is then required coverage. If you choose to break out these two, that's your guys' choice, but it would be my recommendation that just leave it at subsector 457, and then that will encompass all fuel stations and fuel dealers.
If I can just actually ask a question in there with the, we've got, so there are big box stores that are retailers that also have gas pumps. Could you just talk a little bit to if the person is working at the gas pump as opposed to, stocking turtlenecks inside, is that parsed out in the, or is there some way in which these big box stores, now that because, I'm sorry, I've got my page folded up. With the, is that merged in now, or are they still separated up?
So, Madam Chairman, I would have to look within our system, but I can tell you in general, the NAICS code that is assigned to someone is generated from their primary source of income. So if they are, a big box store that generates most of their income from the retail side, they wouldn't necessarily be separated out. Some may choose to do that, but again, that would be their choice.
Did I hear a question down here? Representative Connolly.
Thank you, Madam Chair. And Mr. Wolf, I'm curious about your recommendation that we just include subsector 457. And so if we did that, when we look at page 4, line 19, it is subsector 457. Do we then get rid of all the specificity regarding 4571, for example, on line 22, and then line 25, going on to the next page? Should we just get rid of those because they're already included under the broader 457?
Madam Chairman, Representative Connolly, that's exactly right. My recommendation would be to strike page 4, line 22 through page 5, line 16, and just leave it at page 4, line 19, subsector 457.
So is there another 4573, let's say, that we would be inadvertently bringing in that is not brought in by having it split out?
Madam Chairman, no. Subsector 457, and I have a list here that I didn't submit. I found this afterward, but if we leave it at subsector 457, we will cover everything, including gasoline stations with convenience stores, what is classified as other gasoline stations, and then 4572 starts fuel dealers.
And there's no 4573?
There is not, no ma'am.
So it would just include everything that is there now, just shortening it up.
Madam Chairman, that's correct.
Madam Chair,
One moment, Representative Brown.
Thank you, Madam Chair. Jason, just a quick question on this, and with this being my first dive into this particular area, when we're looking at doing this workers' comp coverage and we're looking at expanding this pretty generically, I mean, we're talking about people that are going to be, for lack of better terms, just sitting there at a cash register taking and receiving payments and whatnot. What other states are updating their laws that are self-funded like we are for workers' comp and whatnot? What other states are doing this exact same type of situation? And is there a requirement to do this? Or is this are we forced, are our hands forced on this? Or are we just keeping up with current federal issues?
Mr. Wilson.
Madam Chairman, Representative Brown, I'm not 100% sure what other states. I can tell you there's 4 other states that are what we call exclusive state funds, and that's North Dakota, Ohio, and Washington State. All of those funds use the NAICS classification system. Some other private funds use what's called an NCCI classification system. Similar in nature to the NAICS classification system. The only real difference is it further breaks down industries. And so where you might have like 140 codes within the NAICS manual, the NCCI system has over 500 classifications.
Did you have a follow-up?
Yeah, I guess more directly, Jason, my question is are we required to update this statute to be in compliance with a particular federal issue that we're trying to go to, or is this an expansion based off of just the NAICS saying, hey, this is now considered extra hazardous? I think the extra hazardous certainly came out of the COVID world, right? Where we had people that were required to be where they were at for a period of time, but there's also other factors that are going into this. And my question is directly, why the expansion? And I know I'm coming to this at the 11th hour asking some silly questions, but I'd like to know exactly what the reasoning for this expansion is.
And so if I can just say, Representative Brown, so the extra hazardous categorization comes from the legislature. And it certainly has been this way all my time in the legislature, because we have a lot of hazardous jobs in our state, oil field workers. The reason for meat markets is that people chop their fingers off with the butcher knives. And so that's from us when we redid our workers' comp system some decades ago. we decide which extra hazardous jobs have to be covered under the state plan. But Mr. Wolf can probably say it better and more correctly than I.
Thank
I
you,
just like to
Madam-
practice.
Madam Chairman, that was a great explanation. And I would just to clarify, Representative Brown, we are not expanding. All we are doing here is taking the numbers that were once enumerated by this legislature at one point in time, and now we're updating those numbers to just keep pace with the NAICS manual. So there is no expansion. We're not adding any other industries. We are simply just keeping pace with what the manual tells us.
Well, Senator Hutchings, did you have a question?
Yes, thank you, Madam Chair. And I'm in agreement with Representative Brown on this. You know, when we get this, we read it and we try to digest it, there are concerns. And I don't think his question was silly or, you know, inadequate. I thought it was a good question, because I too wonder why we're changing these codes. What will these codes mean to the Wyoming citizen? And I'm sure there's somewhere online where we can go out and find all these codes. You said you had a list there. Maybe you could provide that to us so I can see specifically what the new 4248 means versus the 4228. Why did they go in and make changes to numbers? It just seems like a waste of time, or more work for someone to have to go in and make these changes. If you could follow my line of questioning there, I'd like answers to those. Thank you.
And I'll just insert there, my familiarity with NAICS codes is as a business owner, when I file my taxes, I have to identify what is the NAICS code under which your business, that defines what your business does. So I don't, evidently, Mr. Wolf said that there's a big list on the Census Bureau site, but I know certainly in the tax forms, there's a big list of NAICS codes and I pick from above them, and I have never had to change it in all my business years. But if they inserted another one, for example, decided that now instead of having sheep production, we're going to have ewe production and lamb production as separate codes for some strange reason of their own, that would be a reason to insert a code. And before Mr. Wolf answers that, there was another question from Representative Ott. Let's group them together so he can give us, go ahead, Representative Ottman.
Thank you, Madam Chairman. And this is just a follow-up and a point of clarification for myself. With this extra hazardous, is that going to change those employers that have the optional coverage to required? Is that going to change the amount of people that are required to have the unemployment, whereas it was optional for them before? Thank you.
Okay,
Okay.
do them all, Mr.
Madam
Wolf.
Chairman, I'll answer that one first from Representative Ottman. The answer is no. All we are doing is changing the numbers to correspond with the NAICS manual. The people that are covered today will remain covered. We are not telling any other industry that they have to have our coverage. We are simply just updating these numbers, basic cleanup bill for that. If that answers your question. Okay, so
Well,
on to
let's see if we.
Senator Hutchings.
I see we have several, let him answer Senator Hutchings, and then I'll take more questions.
And Madam Chairman, in answer to Senator Hutchings' question, I think, and I'll make sure I try and get it all. The reason that they update these, and they don't do it that often, again, they do this every 5 years and they look into, you know, what the current market is. A good example of why they update these is because industry kind of changes. And so what's included in one industry one day might not be included in an industry 5 or 10 years from now. A good example would be transportation, for example. When they classify transportation, there's bus transportation, there's, you know, all sorts of different, there's truck drivers, there's all sorts of different transportation. When over time that industry changes, they look at these class codes and say, well, it doesn't really make sense for this. You know.
So they took out the horse and buggy code recently?
Madam Chairman, correct. But the reason they look at these is really just to kind of give make sure that employers are, one, classified correctly. The other thing that this does is if at one point, say the, a taxi driver business was included in lumped into a generic transportation code, they might separate that out from, say, truck driving transportation. And that might lower a person's rate that they pay premium. And again, that's an important part of what this system does. It classifies employers into groups, and then our actuary for the workers' comp fund looks at all of the expected losses and actual losses within those industry groups and determines what rate they will pay per $100 of payroll for employees.
Representative Hallinan, did you have a question?
Yes, Madam Chairman. I think the only issue that that this bill represents is a change in the classification of the industry group, gasoline stations, and fuel dealers. And the other issue in this bill, I think, is the part that has to do with firefighters and parole officers and probation officers. The rest of these items are just changes in the numbers that these sections of the bill represent. Isn't that correct, Mr. Wolf?
Mr. Wolf?
Madam Chairman, Representative Hallinan, that's absolutely correct.
Senator Furphy, did you have a question?
Thanks, Madam Chair. I just wanted to make a comment regarding why these changes are important to keep up with the national code. As a banker, when we're analyzing a business, we go out and use these codes, and there's a national data bank of financial statements based on the average in these industries. So when we're financing someone, we go out, key in this code, and compare them to the national data that's out there to determine, are they way out of line? What's going on? So I just wanted to explain an application that's very important for our state to stay current on these codes.
Very good. Thank you, Senator. Okay, Mr. Wolf, I think we left off in the middle of page 5, if you want to pick up.
Okay, Madam Chairman, moving on. Let's see, the next sector, starting on page 5, line 18, would be sector 51, and that is our information sector. Again, just a couple of changes there from lines 20 down through 25. And again, a staff comment at the top of page 6 does state that the manual now says instead of uses the term directory instead of database. That would be your choice to change that if you choose to. Again, it's not going to add any other businesses in there that aren't in there today. It's just a wording change. We would be good with that as well. On page 6, moving down to line 16, this is the public administration sector. So this would be like your city, county, state governments. For whatever reason, this was a change that we caught. I think our statute had been incorrect for a number of years, and no one ever caught it. But we are changing that 92215 is actually parole offices and probation offices in the new manual. So we are requesting that change. And then making the recommendation at the top of page 7, lines 1 through 8, that we add the industry 92216, which has been always covered under the statute.
Which is actually so that's actually the correct code for the fire folks.
Madam Chairman, that's correct.
Got it. Okay.
Okay, and then I think, Madam Chairman, just the staff comments at the bottom of page 7 of what was deleted, and that concludes kind of the walkthrough of the bill. Be happy to answer questions.
So just to make sure I understand, the repealer is basically just what's on page 8, the fuel dealers, because fuel dealers is now being inserted in the part on page 4. Is that correct?
Madam Chairman, that's correct.
Okay, any more questions from Mr. Wolf? Yes, Representative Worf.
Madam Chair, I do apologize for being late too. I apologize to the committee as well. I guess the question I have, Mr. Wolf, when I look at this, it looks like you copied C and made it D, and we just changed C to be parole officers and probation offices.
Madam Chairman,
Wolf?
Representative Worf, that's correct.
Is there any further explanation, like, for example, if you look at D, it goes fire protection, including firefighters while performing under the direction of duly authorized officer in charge and engaged, et cetera, et cetera. Is there any explanation as to parole offices and probation offices that follow that as well? Because I guess that's one of the questions I have is why is it important that we spell that out for the firefighters, but we're not doing that for the parole offices and the probation offices? Should that also have some type of a flow as far as they do for the firefighters?
Madam
Mr. Wolf?
Chairman, Representative Worf, I don't have a real good answer for you on that. I don't think there should be, but I didn't print all of this list that I have. If I remember correctly, just looking at it online, that's just the language that they use is just the probation and parole officers and probation offices for that industry 92215. So I don't think, again, this D that you see here, I think would have been language from the legislature years ago when they made this. So it would be the legislature's choice to add anything to page 6 to specify anything else on probation parole offices, if that makes sense.
Representative Worf.
I guess one of the questions I have, I thought it was answered, but I just want to know that I understand the code, all the numbers that we're changing, like the example that we mentioned, the very first one is 422 goes to 424. Does that also have a definition that follows it, such as this on subsection D, or is it just the code?
Madam Chairman, Representative Worf, I apologize. Yeah, now I get your question. No, the NAICS manual is fairly generic. When you pull it up online, and I can send you this sheet, it just gives kind of a couple word description of the industry.
Okay, and follow up, if I may, I guess that's the concern. We're creating a new category, and I guess that's the only question, and I'm going to throw it out for the committee. It's up to you guys to decide whether we need to go into that. I'm not sure why it's important that we spelled that out for the firefighters, but I know that our parole officers and the probation offices, I mean, those offices also deal with some pretty contentious issues at times, and it may warrant more explanation. I'm not sure what the basis of doing it for the firefighters, not for the law enforcement, but that may be something that we can have our LSO attorneys look back and find out what the basis of that was and see if in fact that's warranted. That's the only question that I have, Madam Chair. Thank you.
That's a good thought. And you know, what I would suggest at this is because rather than have us try to draft something that encompasses all things that are meaningful to, I mean, parole and probation offices without statement here covers, I think, probably everything that they do. Maybe there was something inserted, but rather than try to word craft that here, probably better to request LSO to just do a little, you know, because see what the discussion was when this firefighter language was inserted in, when that happened. And, you know, that can be dealt with during session.
Yes, Madam Chair, and
Much
that's
safer.
exactly what I'm saying. I just see that as maybe a flag that needs to be looked at. I'm not suggesting we do anything here. That's not at all.
Probably some poor firefighter standing by the side of the road with his boot, raising money for cerebral palsy who was hit by a truck is probably, and then someone probably came to the legislature and said, You should be covered.
I'm sure there's a reason.
I'm sure
somewhere,
there's a reason.
But we
That's right.
probably should find out why.
Okay,
Thank
more
you.
questions for Mr. Wolf.
Madam Chairman?
Representative Flitner.
Thank you, Madam Chairman. I just had a question, like on page 4, with regard to the staff comment, if we were to adopt retailer versus market, is it necessary for that to be defined, or are there definitions? I apologize, I haven't looked up the entirety of the statute to see if definitions were included. Thank you.
Mr. Wolf.
Madam Chairman, Representative, I don't think that there is a definition included of retailer or market. Again, I think that's just a simple wording change that the NAICS manual made. To my knowledge, there is not a definition included in the NAICS manual, but we can check that.
Probably is not a definition for market either. As far as, you know, if you're selling beef from your house. And of course, and I don't know, Representative Flitner, if that was your thought, to Mr. Wolf's answer to my previous question about the majority of your work. You know, if you sell your FFA lamb, it's not the majority of your work, I suppose, but good question on the definitions. We've become a little paranoid about definitions. Okay, any more questions on this bill for Mr. Wolf? All right, thank you. Is there any public comment on the bill? Do I hear a motion on the bill? So moved by Furphy, seconded by Brown. Is there any discussion on the bill? I have some then, if no one else does, which is I would amend, I make a couple of amendments, and I can explain it if I have a second. On page 4, to insert the word retailer instead of markets on line 3 and line 6. Okay, I was going to do it all in one thing, but we can. I don't think anyone will want to divide it. And then on page 4, delete lines 22 through page 5, line 16. On page 5, line 24, delete database and insert directory.
I'll second.
Seconded by Flitner. Any discussion? Okay, all in favor of that amendment, please just raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. Okay, that amendment passes. Did you get that, Clarissa? Got them all? Okay. Any other discussion on the bill? Okay, question on the bill?
I have a amendment, Madam Chairman.
Representative Hallinan.
Thank you, Madam Chairman. On page 6, section D, NAICS Industry 9216 fire protection, including firefighters. I would delete everything after that line, after that word firefighters. So that would cover the firefighters in every kind of activity that they do.
Is there a second for discussion?
I'm sorry, Madam Chairman, if he could please repeat that. He said page 6, but I think you meant page 7.
Page 7. Thank you, Madam Chairman.
Okay.
Okay.
Page 7,
Okay.
section D, NAICS Industry 9216 fire protection, including firefighters, period. And I would delete the remainder of that section.
Okay, Representative Worf has seconded it for purposes of discussion. Is there some discussion? Representative Brown.
Thank you, Madam Chair. I guess I would be more curious as to maybe staff and whether or not maybe Jason had had discussion on why this expansive language was originally added. I tend to agree with the amendment. I think the amendment then encompasses basically anything a firefighter does, but I didn't know if maybe there was a specific reason. And so I'd be curious if maybe Jason or staff has an answer on that.
Madam Chairman, Representative Brown, as Madam Chairman alluded, this has been in statute as long as I've been around, which is almost 20 years. My guess is that they were trying at some point to narrow the scope of what would be covered or expand the scope. And that's why you see that they, are covered under performing duties of competition or other things like that. So, staff attorneys may have a better idea why that exists, but that's my guess. Thanks.
Representative Worf.
Thank you, Madam Chair. I did second the motion just because I thought we need to have the discussion, but I'm reluctant to just wipe it out because I think it's there for a reason. And I think it would be unwise for us to take that action today. I think we got plenty of time. I don't see this being a heated issue. And I would rather have the research done to find out what the basis was for that inclusion. And most likely I won't be here. This is my last labor and health meeting, but that would be why I will vote against the motion, but I do think that's a better action. Thank you, Madam Chair.
Any other discussion?
Madam Chair.
Senator
Madam Chair. Thank you. I agree with Representative Wolf on this one. Sometimes when we see a narrative expanded like this, someone did it for a reason. And for us to just arbitrarily come through and just say, oh, let's just take that out. I would like to know why it was there, why the expansion, something specific happened. So I will be a no on this particular motion as well. Thank you.
Okay. Senator Hutchins, or Baldwin, I'm sorry.
I can be whoever you would like me to be. I would like to make a suggestion, Madam Chairman, that those who will still be around, and hopefully on this committee in the upcoming session, take this topic, do some research with the State Fire Marshal's Office, et cetera. See if we can give some more explanation, but I would certainly encourage a no at this time. I hate to remove something when we don't know the real reason why it's there. And I think it certainly warrants more investigation. And I think another member could dig into that before this comes to the session in whichever committee it ends up in, Senate or House. And we can talk about it then if needed.
Okay, further discussion on the amendment? Okay, all in favor of the amendment, raise your hand. 1, 2. All opposed? More than 2. Okay, that amendment fails. Okay. Hearing no further amendment, would you call the roll on the bill, please?
Madam Chair, this is a roll call vote for 23 LSO 237, North American Industry Classification System Amendments as amended. Senator Furphy?
Aye.
Senator Hutchings?
Aye.
Senator McEwen?
Aye.
Senator Wasserberger excused. Representative Brown?
Aye.
Representative Connolly?
Aye.
Representative Flitner?
Aye.
Representative Hallinan?
Aye.
Representative LeBeau?
Aye.
Representative Ottman? Representative Stivar?
Aye.
Representative Worf?
Aye.
Co-Chairman Baldwin?
Aye.
Madam Chair Wilson?
Aye.
Madam Chair, we have 13 ayes.
Okay, very good. All right. Representative Connolly.
Madam Chair, before we move on, could I ask the department a question?
Sure, I have some questions for them too, so go right ahead.
Thank you, Madam Chair. Mr. Wolf, we passed a great little bill last session regarding kind of workers' comp and obligating the department to provide additional information for employers for those individuals that aren't covered by mandatory workers' comp. And I'm curious if you have started that process.
Madam
Good
Chairman,
question. Mr. Wolf.
Representative Connolly, yes, we not only started it, we've completed it. We do have some new manuals out posted on our website for folks with additional resources to contact resources for those that aren't covered by our state workers' comp fund. For instance, big box retailers may be covered by private industry. There's links to Department of Insurance, who regulates them, and they, all the other resources that might be available within our shop to help those folks. So,
Thank you, Madam Chair, and good job.
thank you.
Very good. Okay, I have 2 questions for Ms. Gagan. The first is, you all sent out a letter about the report from the actuary. And I'm glad the report says that you seem to have a sufficiency of money in your pot, so that's good. The main question I had was there not an actuary in Wyoming that you could find instead of one in Ohio?
Madam Chair, Mr. Wolf has a better.
Mr. Wolf looks like he's blushing, actually. Is that possible?
Madam
Mr. Wolf?
Chairman, so like with all state procurement, we go through an RFP process. The actuary that we currently use is Oliver Wyman, who is out of Ohio. For whatever reason, Cincinnati seems to be a hotspot for actuarial firms. There is when we RFP'd this service, which we do every 3 years, there is a lot of actuaries who respond to that from the state of Ohio. We've used this particular one for about 7, 8 years, I believe. Truthfully, you don't get a real good response from it. I don't believe the last time we RFP'd, we did get anybody from Wyoming.
Very good, thank you. That answers that question perfectly well. And I did have another question, and I'll just start with Ms. Gagan. So I have, and I know you can't really talk about ongoing litigation, but I've read about Workforce Services filing a discrimination claim against the Casper Rescue Mission and I'm just wondering if you can tell us at least what the status, where that is in the legal process?
Madam Chair, and you are correct that we don't generally comment on litigation, but I can certainly just give you some historical background. The department did not file a discrimination claim against the mission. Rather, someone who had not received a job at the mission filed a complaint of discrimination. And where we are right now is that a complaint has been filed against Director Cooley in her official capacity, as well as the Equal Employment Opportunity Commission. And we were served with that complaint last week, so the Attorney General's office is working on filing an answer.
Okay, very good. And committee, as we say, we don't generally discuss active litigation, but I just wanted to bring that up. Okay, so that's all I have, and thank you very much. I think that's all for you folks today. Let's see, and this can't be. We're 18 minutes ahead of the schedule. I probably jinxed us by bringing it up. I would, let's see, do we want to, what?
What's the
It says 9:30.
9:15. It says 9:15 on mine.
Oh.
LSO stopped us.
What was that all about? Updated, oh, maybe I have an old one. Okay, well, I better check, make sure I got the right agenda then. Here we are, okay. Fine then.
Still don't tell yourself short, we're still 3 minutes.
No, well, let me just. Okay, we're gonna keep going to the update on the behavioral health redesign. Oh, that's right, I do remember this discussion. I'll put away this other piece of paper. It's misleading me. Okay, update on behavioral health redesign. Gee, I seen some of you guys earlier this morning.
Good morning, Madam Chairman, members of the committee, Stefan Johansson, Director for the Wyoming Department of Health. It's good to be with you this morning, and we'll try to do the best we can with the time, so we're maybe more than 3 minutes ahead of schedule. I'll be brief. We wanted to provide an update to the committee on the work that has transpired in the behavioral health reform over the past interim period. There will be, as you've seen, some small legislative tweaks that the steering committee and the stakeholder group, including the providers, will recommend. But if it's okay, Madam Chairman, I just wanted to provide a very short background on why we're here. And I'm joined today to my left by Matt Petrie, who is the Senior Administrator of our Behavioral Health Division, which oversees community mental health and substance abuse services, and the esteemed Representative Lloyd Larson to my right, who's really been working with us hand in hand since the process began. In the presentation, Madam Chairman, that the department provided to the committee, which you should have, I'll be very brief on the first couple of slides. It's really a background, but if you'll indulge me again, by way of background, I'll just say that this redesign came about for a variety of reasons. And as you'll see on slide number 3 with the problems that we hope that this reform and this redesign addresses, we've had an undefined mission for the community mental health and substance abuse services over the past several years with the evolving landscape of behavioral health around the country. different types of coverages, different types of financing models that have been introduced. And with the system in Wyoming that was set up in the 1970s to fund mental health and substance abuse centers on a general access basis, what we really observed was the lack of that state policy or mission to tell the department ultimately how to spend those funds and who, especially with the populations that are slipping through the cracks, ending up in institutions, cycling through the state hospital, correction systems, et cetera. I think the general consensus of this body, and certainly from my perspective in the executive branch, is we can do better by those people in providing community services through our partners that we've historically had in community mental health and substance use. As I mentioned, you'll see bullet number 2 there on slide 3. There has been a changing landscape of behavioral health and mental health coverage around the country. And that makes the economics very peculiar of something like state-funded mental health and substance abuse, where essentially over the past 10 to 15 years, with various insurance reforms and new coverages, a broader part of the population, certainly not perfect, but a broader segment of the population has more access and insurance coverage for behavioral health related services. So essentially what we've observed is a little bit of unsustainability of the financing for our community mental health centers that we've been partnering with for over 40 years. And that was very concerning, certainly to me, several years ago, as we started to observe financial issues, bankruptcies, consolidations, some of which, consolidating can be very positive, can achieve economies of scale, et cetera. But without that defined mission, without the state coming together between branches and really setting the policy of who we should be serving and how we should serve them and how we can appropriately finance our providers to keep them in business, we were really staring down some issues. And that's the broader reason for the bill that passed in 2021 and that was continued this previous session. As a little bit more background on slide number 4, you will see that we spend approximately $100 million in this line item per biennium, about $50 million a year to fund community mental health and substance abuse centers. And there's really a tension, as I've alluded to, between two primary objectives at the state level. One, as I was mentioning earlier, ensuring that our high needs folks have the services and the supports that they need. And I would add that those who care for them in the community are compensated accordingly for it. That's certainly an objective we would all agree with. A second objective I think we would all agree with is ensuring more broadly around the state that our general population has access to behavioral health services. And that's a tension that's difficult to resolve, and one that for the past 2 years we've been working diligently with the stakeholder group, legislators, providers, others in my department, Department of Family Services and Corrections, to try to balance those two priorities. I'm not alone in the Department of Health with the priority populations that we really struggle to serve, and we see having these negative outcomes with recidivating in institutions and really struggling to provide that adequate care. Department of Family Services with high needs children, adolescents, and their families. It's an every week, if not every day, endeavor for myself, Director Schmidt, Department of Education, and local folks. Department of Corrections, who's at the table with this effort. Similar issues when we see folks discharging from state level and local level corrections and perhaps not receiving the supports that could keep them from recidivating back into institutions. So a large part of this effort is to reconcile these two objectives and again, really set the state policy of how we should be funding my second largest line item in the budget, which I know there's always talk about what more is needed and systems that are underfunded, but it's important to remember how much we do across Department of Health, Department of Family Services and Corrections in attempting and trying to pay for these services and have those policies that really achieve the best outcomes for these folks, which we'll get into. I'll skip over.
Madam Chair.
Senator Hutchings. Oh, you're on mute.
I'm only interrupting, thank you, because I wanted to discuss something on this slide before he progressed. So if I may, Mr. Johansson, you talk about all the things you want to do. You want to stop this, you want to stop that. But when we have communities where we have mental health issues that are mainly caused because of the substance abuse, sometimes there's just nothing you can do. So when you guys kind of talked about that? Sometimes there's just nothing you can do. You can have all the access to food and health and shelter, all this you want, but if someone does not want to come in and receive that assistance, you have to come to that, I guess, to that point and acknowledge that you can't help everybody. So have you come to that point, or have you talked about that? I guess is my question. Thank you.
Madam
Director
Chairman,
Johansson.
Senator Hutchings, I'll be brief. I know Representative Larson might want to weigh in there from the steering committee's perspective. But Senator Hutchings, it's a good question, and the answer is yes. That has come up numerous times, not so much in the vein of when there's nothing that can be done to help someone. Obviously, that's not the spirit of folks who do this work on the ground. But your point's well taken in that I think the goal here is not necessarily for the state to dictate every service that should be provided to someone, whether it's, we see a dual diagnosis of mental health and substance abuse, to your point. The state should not be in the business of telling providers locally how to care for someone. That local tacit knowledge is important. Instead, Senator Hutchings, what we're trying to set up, especially in the outcomes payment model that we will get into today, is to align the financing and the incentives appropriately to where we set up the providers to have it in their best interest to be creative, especially on those social outcomes that you're talking about, housing, et cetera, and wrap those around the actual services that are being provided. But you're absolutely right. We run into cases all the time at the state level, and certainly I think that would be the case at the community, where folks run into a brick wall and say, we don't know what else to do here. This person will not come in for services. And that's where our partnership with the judicial branch, which again has been very positive over the past 1 to 2 years in building this effort, is what are those legal tools when necessary and appropriate, whether it's a diversion from a civil or a forensic commitment in Title 25 or Title 7, to have an outpatient commitment type option where there is a little more teeth to essentially incentivize the client to receive those services. That is certainly, Senator Hutchings, on the table. We have those vehicles in statute in Title 25, not so much in Title 7. There are some in the correction system, as you know, where conditions of probation and parole do dictate, certain treatment obligations. And part of this effort will be to bring our community mental health centers more into the fold in that work, which they absolutely want to do, and ensure they have those kinds of tools that are necessary. But Senator Hutchings, don't hear me say that this is an easy issue to solve. It most certainly is not. And I know that wasn't the short answer I promised, but I'll defer to Representative Larson if he has comments there as well.
Representative Larson.
Thank you, Madam Chairman and Senator Hutchings. Chairman Baldwin and I have served as the co-chairman on this mental health subcommittee, and I think it's really important for everybody to remember that the guiding principle in this whole redesign was what's the role of state government in providing these services. And so as we've worked with WAMSAC and the providers to put into place how we can prioritize and make sure that these priority populations have services available to them that maybe they haven't had to the degree we felt has been warranted previously, it doesn't take away an individual's right to reject those opportunities. So, and we had that conversation during the course of some of our meetings, where particularly you may have a handoff coming out of the judicial system, coming out of corrections, and somebody's on parole, and the requirement is then for them to come into the community mental health provider for the services they need. The providers were concerned, what if they don't show up? And those
that may very well happen. And we won't hold the providers responsible for that. And we can't take away the rights of the individual. But by making those choices may impact his or her ability in the future if they don't comply with their probationary requirements, or if their mental health concerns create an environment that finds them being involuntarily committed, or they commit some other crime. So they're free to choose, and we're just trying to identify what the state's role is, make sure that we have the foundation there for those services of the people that need them.
Okay, go ahead, Director.
Madam Chairman, members of the committee, moving to slide number 6. Again, I'll be brief here. Our desired end state, as we presented to you last committee meeting, is relatively modest here, although this is an inordinately complicated redesign and reform effort. We want people in state institutions, whether that is in Department of Health, Family Services, or Corrections, to be actively pulled back towards the community. And that's both from a treatment and a service delivery perspective, and as I've mentioned, from an economics perspective from the state. How do we align those incentives and the dollars and cents? Also, we want those high needs individuals that we see in multiple state systems to not fall through the cracks and to be prioritized as the legislation that the legislature passed in 2021 dictates. Finally, Madam Chairman and members of the committee, I'll mention, because this is one of the more innovative and exciting implementation aspects that we have in this reform, is with a segment of our budget here to pay for what we want. Those of you on the health committee who have attended conferences, legislative or otherwise, you'll have heard this buzzword that we're all tired of, which is the social determinants of health. Everybody talks about that. Everybody says that's the key to success, especially in behavioral health. And very few entities take ownership of it. We all say it's housing, it's education, it's work or volunteering that really determine or correlate to those better outcomes that we see. But it's rarely anybody's job to own that. We have and we've worked with the providers diligently on this, and I'm excited of where we're going. We have an opportunity here to carve out a segment of the budget to do a true outcomes-based payment program, in addition to financing the infrastructure and the services that they provide, which is necessary, but to pay for things like when a client is housed, whether that took a lot of resources to achieve or no resources to achieve, to provide an incentive payment or a bonus payment to providers. Same thing for competitive employment, community engagement, volunteering, attending school if you're in that age group. These are things that we know correlate to better outcomes for this population, and we are going to design into this a system to pay for that, to reward that, both from the client and the provider perspective. And we'll get into some of those details, but that is one of the more exciting aspects of this. For the previous work that happened, members of the committee, there were really 3 major work products which you've seen, so we'll be brief here. And that was on eligibility, what that looks like from a client and service delivery perspective. That was work that was done in 2021, as well as defining a list of desirable outcomes, some of which I just mentioned. There's a whole host of things that we always need to monitor and measure as it relates to the provider business and various things that we've monitored over time. But we're really taking a concerted effort to make the actual outcomes for the client meaningful and achievable for the providers. And finally, in 2021, we also worked on what do those transitions look like from different levels of care? How do they arrive at these facilities, or how do those warm handoffs work between state entities and local providers? Now, moving on to slide number 8 and 9, the recent work from this past summer. Again, very pleased to report to this committee and brag on the group that worked with us over the summer, legislators, providers, other stakeholders. I thought it was very productive, and we have some good work products here. We focused on payment. We focused on what does the payment model look like? And we're in a good place conceptually of how we're moving forward, where the work in 2023 will really be designing the nitty-gritty of how those dollars flow, how systems work on the eligibility side, on the service payment side. But you can see here as a general summary, kind of the current state on the left in terms of the percentages of where the funding goes, and what we've come to agreement on the desired end state in the redesign. And it's not too different, but it really breaks into 3 buckets, as I mentioned before. We want to make sure with these safety net providers, these community entities that are quite different from, you know, a private psychologist that you or I might seek services from. A community mental health center is really an anchor in the community that is geared to provide a wider range of services. So the committee and the stakeholder group did believe that it would be warranted to increase that base payment funding because of what we've seen in the market of mental health with, you know, financial conditions, consolidations, et cetera, that it's in the state's interest to essentially subsidize that infrastructure, some of which we do now, but you can see the percentage of that in green really increasing in this model to ensure that we have a long-term commitment from the state to keep these providers in business. About half of that bucket that you see on the right there would be for your service payments. So both outpatient and residential, certainly some issues to work through there of how we contract or how we pay for those. And that's on the agenda for the next interim year that we will really get into the weeds there. But there was general agreement that about half of the funding would flow to compensate for the services that are delivered. You know, the units of service, whether that's on an outpatient basis or, you know, bed days in residential, et cetera, would comprise about half the budget. And finally, as I mentioned, a small but meaningful portion, 10% carved out for outcomes-based payments or incentives. And we do think as a group, this 50-40-10 split is appropriate, especially in the first 2 years of implementation, where we minimize system shock. If we were to dramatically blow up the financing model, that's always difficult in any sort of health and human services.
Representative Brown.
Thank you. Director Johansson, just a quick question for you. We look at this, you say you're about 50 million a year, and then we're splitting that 50-40-10. But, you know, again, coming to this committee is fresh and green behind the ears as I am here. One of the things that I continuously hear is that we don't have enough providers, right? And that we're short on providers. Has there been a discussion with you and the working group about looking at asking for an increase from this 50 million to try to bring in additional help, to try to bring in this lack of providers in the state? I mean, I don't necessarily want to be the one that says, hey, the state needs to bring in providers at all times, but has there been a discussion with this? Because clearly those are the people that need it the most. Has there been that type of discussion? It looks like.
Madam Chairman, Representative Brown, again, this time I really will be brief and defer to our Appropriations Vice Chair here. 2 things that I would mention, though, Representative, is yes, those conversations have happened. Part of what I'll continue to mention and advocate for in terms of this reform is that when this policy is now set, we are actually distinguishing work that community mental health centers do that is by definition different from a broader provider community that might certainly does good work, but has a narrower scope. And by setting this policy and financing it appropriately, I do think that we are financially setting the providers up for more success. Essentially, on the state side, with the state dollars, shrinking or targeting the population and providing additional compensation for that. Over time, theoretically, that could provide a more stable, you know, market and potential other provider entrants that could come to the table. That's certainly not a guarantee, and it is an issue in Wyoming with having access in every county or every community to this type of service. Regional services and things of that nature will be necessary. The second point I would mention is more on the technical or specific side. We do have a draft budget request that was part of the legislation in this past year's bill for things like transition funding, various system investments that the state might want or need to make this transition successful. And we'll see how that fares in the session, but that would be in addition to the budget that we have now. In closing, I would say I don't know what the magic number is for, you know, is $100 million a biennium enough for this? Is it $1 billion? Is it 20 million? It's hard to say. But what this will give us the opportunity to do is, with this priority population that we will essentially be financing and serving, over the first couple of years, we will set this up where things can be pretty rigorously studied on, what were those per member per month costs? Did the outcomes payments have an impact on recidivism? What did it cost on the residential side? And that puts a little bit of risk on the providers, and they've voiced that, which I understand as part of this process. But it will give us an opportunity to look at, can we put our fingers on, should there be an increase, or are we stable as is? But Representative, please.
Representative Larson.
Thank you, Madam Chair, and Representative Brown. I think, though, it's really to look at the global picture for mental health and who provides those services. We're focusing on the community mental health system, which was established back in the 70s and has really morphed some, and we hadn't kept up to speed with how that has all evolved. So we just, you've got that community mental health system that receives funding from the state. Then you have the whole host of private providers, psychiatrists, psychologists, counselors out there hanging their own shingle. And so I just want to make sure, based on your question, is we recognize the need for more mental health in the state. Again, what's the state's role in doing that? And this focuses on that community mental health sector of that mental health responsibility the state has. And we think by prioritizing these, it's made a more defined line for the private sector to not feel that the state is subsidizing patients that they too could be seen. So this enhances perhaps those who want to come in and practice separately and do these sort of things. This does not prevent a community mental health center from seeing these traditional payments, insurance, self-pay, or whatever. They can Medicaid reimbursement that our private providers are, but we've just used this priority population and defined how this population that we really think is the state's role in providing services.
No, that's good, and good questions. And just to sort of bolster the background, so last year, the committee brought, and a bill was passed to require that payments for mental health services had to be made by insurers at the same rate as if the person were seen in person. We didn't go to physical health like bronchitis over the telephone kind of thing, but we felt that, especially in the pandemic, but going forward, that was one area where we could make sure that providers were being paid at the same level for if they saw the patient in person. The other thing that you'll see on the agenda going forward in this meeting is we have 2 interstate compacts for mental health licensure that will certainly enhance the ability, especially at the, I would say, like the psychiatric and psychology levels, the higher education levels, for people to access, for our physicians and psychologists to care for people in border areas, or people who've gone home, people who are in Arizona for the winter or whatever, or conversely for border state providers, or we use a lot of, I think, child psychiatry types from Seattle to bolster our ability to provide that way. So it's not just a money issue, it's also a personnel issue, which we've tried to address in some other ways. So good questions. Well, that's good. Representative Connolly.
Thank you, Madam Chair. I have a question for the subcommittee and with the redesign, because the redesign's been going on for years now. And honestly, if I remember correctly, it really has been starting before COVID. And it assumed a fixed pot of money, and that money was not going to expand, which I'll get to later, but decided that because of a state obligation regarding our community mental health services, we should define who would be eligible for those services first. And you can see it on your slides, and it's high needs people, which were defined by the subcommittee to be justice involved, to prevent recidivism, and then goes to general population. And one of the concerns I've always had is about limiting services, honestly, that are really needed in our communities. On the Education Committee, we have heard about a desperate need for mental health services for teachers and other individuals who work in the school systems right now. From my home community, Laramie, Albany County, the front page of our newspaper today talked about a desperate need for mental health services for firefighters, including those who do volunteer services, and that they're going to be contracting out. So that is all the preface to my question about, has the committee actually thought more about prevention, right? That there's a high needs population that you've really been focusing on, but when you get to that next category of what we'll just call general population, the absolute need for increased services for prevention, because we're hearing it over and over again. And as opposed to just going forward as if the pandemic didn't happen and that the services needed are fixed, right? Or the money needed is fixed. Have you rethought in any way what the real needs are in the state?
Madam Chairman, Representative Connolly, big question. Let me take a swing at it. And
Was that to him or to the subcommittee?
I'll take a stab at it from the executive branch. Your point is well taken. It's a great debate in this policy area of where do you put financing, and I don't mean to just be the dollars and cents guy, but if every resident in our communities is a priority, then we see that priorities slip, and that's the frank reality from my perspective. Is I couldn't agree with you more. The availability and the general access for behavioral health services in Wyoming, as with many other services, is limited. It's hard to deliver. It's hard to scale in a place like Wyoming. And historically, our model for this type of work has been general access. And again, at the risk of being overly blunt, an outcome of that has been the patients and the clients and our neighbors and our communities that I see, that Department of Family Services sees, that Department of Corrections sees, slip through that because what our providers have been financed for and scaled for cannot accommodate higher levels of staffing, specialty types of providers like psychiatrists, et cetera. And that's a lot of what this is geared toward. While limited with the state dollars, you're absolutely right. There's an eligibility scheme here. Basically 4 types of folks: acute psychiatric, Title 25 type clients, Title 7 or corrections involved, both at the state and local level, the high needs kids and their families, which is a huge need and priority from my perspective, and then general access through low income, but limited. Although the subcommittee did amend that in the most previous legislation to go up in the federal poverty level. So those conversations have absolutely happened. To your question about prevention, it's a difficult one, but that was a big focus, especially last year, and it came up numerous times in our meetings this year of the providers and some of the stakeholders in our groups saying, we don't just want to be reacting to folks that are coming out of institutions, because we do good work in diverting there. And part of our service delivery payments and our outcomes payments can and will accommodate that. Again, I don't want to overpromise and underdeliver here, because there is a targeting here, and that's the policy debate we've had for several years, as you mentioned, of with the state dollars, how do we prioritize those? This, as Representative Larson mentioned, this effort does not limit a mental health center's ability to serve a broader population, to leverage insurance or other payment sources to do that. The ability to deliver those and staff those services is another story, which is a statewide issue. You're 100% right. But I want to be clear that this reform effort really focuses on what's the role of the state with that budget that you all give us every biennium. And that's where we're having this policy. But more broadly, there's nothing in this that would prohibit a mental health center from doing a couple of things, like serving a general access population, or as Representative Larson mentioned a few minutes ago, to partner with other private providers that might be able to layer services within that organization for this priority clientele. Representative Connolly, I don't know if that answered your question. I'm happy to elaborate, but also would defer to Representative Larson from the subcommittee's perspective.
follow-up, and then I would like Representative Larson to talk about it as
Representative
well.
Connolly.
Yes, thank you, Madam Chair. Thank you, Director. So you did talk a lot about money, even though you said you didn't want to be the money person, and so talked about the dollars that were available, and I know the subcommittee has talked about that as well. And so when I look at the very complicated pipeline chart, I noticed that we as the state are putting in far more money than the feds. And I am just curious, if we did Medicaid expansion, if we could have more services that honestly our communities, our individuals, our neighbors need, and honestly put less of a stress on the state if we simply adopted federal dollars in order to provide these services.
Madam Chairman, Representative Connolly,
Director.
now you're pushing me to be the dollars and cents and coverage guy. Yes, we've done that analysis, and as we've reported to this committee, Medicaid expansion would certainly overlap with this population in terms of insurance coverage. We've done that analysis year over year, and with the folks that are served by community mental health centers, many of them would, just by the financial eligibility standards in Medicaid expansion, would qualify. But I present that obviously without judgment or opinion. It really is just the mechanics of how that would work.
Representative Ottman.
Thank you, Madam Chairman. Hello. What I'm kind of wondering here is that with the populations that we're talking about in the priority, and I've been able to watch that over the last year and a half, and I thought it was a lot of good work that went on. But what I'm hearing is that throughout not only our counties and our state and our nation, is that we're having problems finding providers and workers. So if there are none, it seems to me as though there isn't a lot we can do about that. And so if we look to take people from other places, then does that create another problem? Because within the Department of Health, we also have the Department of Aging. And so how are we going to balance these? Because it probably will be two different meetings where we're talking about these things. So how are we going to handle this? And what I was also wondering is, like with the Life Resource Center, and that how many people can we accommodate at that facility? And how many people really within the state do we have any numbers for how many are needed, and how many we can provide, and how many we can provide if we were fully staffed, and how we're going to work on all those things? Thank you.
Madam Chairman, Representative Ottman, I'll answer them in reverse order. To your second question, I'm happy to follow up with you offline on all of the numbers and modeling we did with the facilities projects for what the projected needs were, both at the state hospital and the Life Resource Center, what that capacity would be, how it works and doesn't work, whether we're staffed or not. And we're experiencing that now with some critically low staffing levels, as you know. And we're not unique. The whole sector in health and human services is struggling there, which leads me to your first question. How do you handle the workforce issues, which does appear to be a separate topic, but is completely related here with, we want to serve a priority population better, but if there are not the people to do that, how do we achieve this? And I don't have a magic 8-ball to look into. If you all know where this workforce is hiding and where they went, please tell me, because it is very difficult to figure that out right now. And as a hopeless optimist, I think the labor market, we're seeing some stabilization, but it's not coming quick enough. We're still paying through the nose for contract labor, things like nurses, various agency labor, and that's for state facilities and certainly in the private sector as well. I will say, Representative Ottman, again, transitioning a bit more to the theoretical, but I'll commit to this, that the state working with us, the legislature, to set the policy, that clarity of who we're serving and what we want to achieve being articulated in statute and in policy, I think is a huge benefit to our partners, to our providers in the communities that will do this work, because much of what they do, depending on what the state is buying or how we contract, is determine how am I going to staff this facility that I operate? What kind of staffing can I purchase with these contracts, right? How do I set this up for the next year in my business, and who will my clientele be? I think having that clearly articulated, that this is the population, we can start to do the work, and so can our providers locally, to project and model out, okay, if I'm going to have, these expectations that the state has set, and it's clear, here's how I need to staff. Here's the types of providers I might need to contract with or leverage via telehealth. So it's kind of a theoretical response to your question, but I'm optimistic the economics will work. Now, again, workforce, whether you work in health and human services, food service, what have you, we're all struggling to find people to take these jobs. But I do think that clarity of policy direction certainly assists our providers in determining how their businesses will operate day to day.
Well,
Thank you, Madam Chairman. Okay, I have been also just talking to people in the community, and I'm sure a lot of them have been talking with you about where the people have gone. Well, some of those answers seem to be that people, particularly with the last couple of years and the things that our country's gone through in the world, a lot of people that were on the cusp of being able to retire have chosen to do that, so they're finished. Another thing is that people that found it very difficult to keep their jobs and who were dismissed from healthcare work because of their medical priorities and their health, they are not coming back. They have found other avenues of employment. So as our mission for the state, apparently we're getting a larger and larger population of people requiring these mental health services, because how did we service them before if not? As that is growing, is our mission, are we going to be flexible enough to say, with what is going on, truly, this is what we can do, and not try to make the world 100%. I mean, we'd all like to do that, but we have to look at the finances and the facilities and the workforce and how this population may be growing and the main source for what that is. So I'm just kind of wondering, because I do agree that it is severe, but I'm just not sure that that we can fix it.
if I may just chime in here a bit as chairman, the prioritization was the entire point of this exercise starting several years ago. The second thing I guess I would say, after 10 years in the legislature, 8 of which on the Labor Committee, is I think as elected representatives, we have two choices. We can either hope that we can make things better and go day by day, step by step, or we can throw in the towel and say Wyoming is in a pit for the rest of the century. Those are choices. And I think those of us who run for office and try to serve in various committees on the legislature to make things better, we have to hope that by continuing to work, we can make things better, or else you may as well retire. Not you, I don't mean somebody else, but anyway. Director Johansson, maybe you would like to.
I will just
continue on.
conclude my comments. You'll see on slides 9, 10, and 11 a breakdown of the 3 buckets that I mentioned with service payments, outcomes-based payments, and fixed payments or infrastructure. Won't go into the details there. We've talked about that at previous committee meetings, but always happy to follow up with any of you with more detail. But we'll just close my comments by saying once again, very, very proud of the work that folks have done and the time they committed to us. Chairman Baldwin, Representative Larson, Representative Provenza, and the provider community, and so many others that worked with us hours and hours and hours over the summer to get where we are today. And I'm really comfortable as the health director of where we're going into 2023. As I mentioned, you have a bill in front of you that that does tweak the statute a little bit, not a very substantial change, with the essential subsidy payments being changed from a shall to a may. That was a joint decision among the steering committee, the subcommittee, and the provider group. But again, happy to elaborate or answer any questions you might have, and would certainly defer to Representative Larson and Chairman Baldwin as the chairs of our subcommittee from the legislative perspective, if there's anything to add. Madam Chairman, stand for any questions.
Director, actually, I do have, so one question there. So you did mention a legislative tweak. So I see at the end of the report, there is a proposed draft. LSO, do we have anything from the point of LSOs, or is the text on page 30 of the report what are we going to be working with that today? And Representative Larson, maybe you have some thought on that?
So, Madam Chairman, thank you. The language that you see there was drafted by LSO.
Okay. So we'll, after, and are you going to go any more on the report, or do we want to just move to the draft language?
If I may, just a little bit, Madam Chairman, I think it's really, I would just like to reemphasize, I think that the work over the interim has really been good. But Madam Chairman, what we've really found over the course of this last year, that the landscape has changed just in the last year for the providers of these services, and they will continue to change. And so these changes have really solidified in my mind the need for these policy changes that we're putting into place and the conformity model statewide, and to provide these services statewide. In the stakeholder meetings, we've had the Department of Health, Family Services, Department of Corrections, as well as the providers represented with WAMSAC. We had the meetings were very well attended, and the debate was rigorous, and the input was good. And I think overall that was a refining process that really led to the legislation. I think that really was generated from the input of the providers. That all along, one of the big concerns you'll recall was we've got to have these subsidy payments because we don't want to lose these providers. And we had contemplated, well, we'll do this within, we just kind of said within a certain mile radius, and we were working to that. But as we finally got to that point and we had put the other components of this foundation into place, the providers come back and says, we don't think we need that. We're okay. And so if we could change that to May, and then have the providers just be able to get that available funding based on the service needs demonstrated by that community mental health center back to the Department of Health, I think really illustrates the level of conversation that we all had in defining this. I would also, Madam Chairman, I think when this committee, because there will be a continued need for deep involvement from this committee moving forward. But if you reflect back over the last 8 years, what we've done at the state hospital, the Life Resource Center, kind of laid this foundation of what's the state's role. Then we embarked on this endeavor to prioritize. And each time we lay this foundation and we're starting up with that course of bricks, which is what we're doing with this component of the mental health redesign, we identify more issues like you're talking about with firefighters and with school teachers. I think that the next one that really is, how do we handle these adolescent kids with really high behavioral needs in the state? We do not have a policy. And so, you know, we have adolescents at risk of sitting in a county jail or doing some of that. And so to Representative Ottman's point on what do we do, and the ability and the necessity that we be nimble and flexible to do some of this, we're starting to see the fruits of that labor. And I'll give you an example. As we had a young female that one went to out of state. We had a female that we were not able to handle with any, an adolescent, weren't able to handle with any facility in the state or the country. A new facility opened up in Ohio, said we can take high on the spectrum there and with autism. Went there, new facility, they contact Department of Health and Department of Family Services as we overestimated our capacity. We can't keep this little girl and we're going to send her back. And okay, well, through the course of this design and trying to think outside the box, one of our community mental health providers said, if you could work with us and be a little flexible, we think we could deal with her. We said, okay. We said, okay. That little girl now is living at home again, is passing all her classes at school. That's where we need to get. And so as we're laying the foundation, we're laying a solid foundation, it gives us the ability to respond more nimbly, and think a little more outside the box. We're knocking down those silos between education and Department of Family Services and Department of Health to have a broad-based thing. I think the direction we're headed is very positive, and we're seeing success stories at this point in that. So I think we're on the right track. Got a lot of work to do. We've still got policy. These adolescent kids, it's a big deal. And how we do that. We're trying to do a little pilot project and see where we can do that. Again, what's the state's role? But Madam Chairman, I think the subcommittee, I agree with Director Johansson, Senator Baldwin, Senator Schuler, and Representative Provenza have been exceptional in that, and really appreciate the providers for their frankness and forthright conversation in this matter.
And Madam Chairman, very briefly, I might have been mistaken. I don't think there is a draft bill in front of you for this. The legislative language is in the report. I would defer to LSO. This might, given the timing, and I believe I'm recalling a discussion from our meetings over the summer that this could be an individual bill. I mean, the change is relatively modest, but I might have been mistaken. I do not see a draft bill in my materials.
And Madam Chairman, I think my good co-chairman and your good co-chairman and I agreed that if you were able to squeeze that in, you would, and if not, that we would do a personal bill.
Well, I think it fits under the scope of our committee assignments to hear the reports and all that. LSO, can we work acceptably from what's on page 30? I mean, there's no reason why we can't consider that a bill draft, is there?
Madam
Sorry,
Chairman.
looking at the wrong end.
It's all right. Madam Chairman, that proposed language hasn't gone through the official review process. I don't know if there might be more amendments that have to be made or what have you. I don't necessarily know that that would be the final product as far as like conforming amendments and things like that.
So if we vote to accept, so starting on the top of page 30, it has a bill for an act, blah, blah, blah. This act is effective. If we were to vote to accept all that language as it is, you're saying that that we can't sponsor it as a committee bill?
I just don't know necessarily that this would be the end result. There might be more amendments and things that I need to make that you would need to approve later
From an
on.
LSO perspective, you mean?
Right, from an LSO perspective. I'm just not sure that this would end up being the final product. And it hasn't gone through the review process or anything like that.
Madam Chairman, may I suggest that that being the case and it's questionable, I would make the offer, I will sponsor this as an individual bill. And I would request LSO to put this forward, get it through the review process with myself as the prime sponsor.
Do you want to take any testimony and all on that now, so that if there are changes, you have them done ahead?
Absolutely. Any comment or testimony I think would be welcome at this time.
Okay. So committee, we're on page 30 of the report. There's proposed bill text. And we will look at that. Before we start working our way through, I'll ask if there's any public comment on the report or specifically the text, the proposed bill draft on page 30 of the report. Hello?
Madam Chairwoman, thank you. Andy Somerville, Executive Director for WAMSAC, the Wyoming Association of Mental Health and Substance Abuse Centers. My comments this morning will be very brief. We appreciate the hard work of everybody over the interim. We think we've come to a good place in terms of moving this forward. The pilot project is moving forward, well planned. We really like the idea of trying this before it goes into full effect the following year, so we appreciate that. Concerning the language change that you have in front of you regarding the essential service payments, I want to assure the committee that was a unanimous vote to recommend that change from all of your community mental health centers, from the very, very tiniest one with less than 10 employees to the largest one with more than 500. We feel it's really important to make that change because 3 years ago, as Director Johansson said, there was 18 community mental health centers when this idea was conceived. That landscape has changed significantly. And while people might think that's a negative, we don't think it is. It's a necessary change in the healthcare continuum for community mental health centers to remain strong and sustainable. And so we think that there will continue to be changes. But one of those changes is that we now have multiple entities that are taking care of multiple counties. Instead of a system, what we had 30 years ago, where there was a tiny little community mental health center in every single county, that has changed. So those services are still in those counties, but you have a county that might be operating in one of our very large urban areas in the state, as well as covering some of our most sparsely populated counties. And so the essential subsidy program doesn't necessarily make sense as it's maybe was conceived a few years ago. And the support for our smaller providers, they feel supported. And like we said, we'd like to leave it as an option if it's necessary, hence the shall to a may, but I just want to assure the committee that that is the case. Madam Chairman, with that, I would ask you to support the continuing changes and stand for any questions.
Questions for Ms. Somerville? Okay, thank you. Any other public comment? Anybody online? No? Okay, then public comment is closed. Is there, we'll treat it as a bill, just for the benefit of Senator Baldwin. So I guess we're not moving to sponsor the bill. He will carry it individually. Is there anyone here who has any input, though, that you would like to give to Senator Baldwin before he takes this back to LSO as an individual bill? No. Okay, there you go, Senator Baldwin. Have a bill. How many can you have? Oh dear. Well, someone might have to help you with that then, if necessary. All right, so that is the end of behavioral health redesign. And I think now would be a good time, even though Department of Health's next item is probably short, but we've been sitting here for 2 hours, so we'll come back at 20 after 10. So we will recess for a 12-minute break.
Good morning again, Madam Chairman, members of the committee. Switching topics from behavioral health to cancer. So not a smooth transition, but this will be relatively simple, I think. We have basically a statute cleanup bill in front of you for a very specific issue, but I want to take this opportunity to introduce to you all Star Jones, who's sitting to my right. She is our Cancer and Chronic Disease Prevention Unit Manager at the Public Health Division. Truly one of our department's best and brightest, and very, very committed to this program, which is so important for early detection of various cancers to prevent negative outcomes and certainly increase cost of that type of treatment. I'll hand it over to Star to present the issue that you have in front of you today. It's a relatively short bill. Not as short as the infamous comma bill from several years ago, where we needed to remove a comma, but one that I think will make sense. And I'll hand it over to Star to introduce herself to you and dive right into the issue.
Thank you, Madam Chairman and committee.
Make sure your speaker's on.
There we go.
Okay.
Good morning, Madam Chairman and committee. As Stefan mentioned, my name is Star Jones, and I'm the Cancer and Chronic Disease Prevention Unit Manager at the Wyoming Department of Health. And one of the programs within my unit is the cancer program. And we provide breast, cervical, and colorectal cancer screenings for Wyoming residents who are at or below 250% of the federal poverty level, who are uninsured and underinsured, meaning that they have an out-of-pocket expense that they cannot afford. The services that we provide are mammograms, Pap tests, colonoscopies, and at-home stool testing options, and we reimburse Medicaid providers for rendering those services to enrolled clients. The reason that I'm here today, as Stefan mentioned, was to propose statute cleanup changes to Statute 35-25-204, specifically regarding the colorectal cancer screenings. There are 3 minor changes that we would like to request, 2 of which have to do with the eligibility criteria outlined in the statute, and the third removes obsolete language regarding our processes. The first and most important of the statute changes that we are requesting has to do with the age criteria that's outlined in the statute. All of the components of the Wyoming Cancer Program follow the United States Preventative Services Task Force guidelines, otherwise known as USPSTF. And in 2021, that task force changed the eligibility criteria for colorectal cancer screenings down to age 45. However, in statute, we do have a specific age criteria listed as age 50. So age is the most important risk factor for colorectal cancers, and 94% of new colorectal cancers are being diagnosed in 45 and older. 75% of those are young onsets between the age of 40 to 49. So when someone does turn 50 and is eligible for a colonoscopy, they're often diagnosed at a late stage. And 40% of people who die from colorectal cancers could have survived if their cancers were diagnosed at an earlier stage. So this goes back to the core purpose of our program, which is to diagnose cancers earlier, to save money for the patient and for better outcomes. The second request that we are making for the statute change has to do with the Medicare eligibility that's outlined in the statute. It states that if someone has become eligible for Medicare, they are no longer eligible for the screening program. However, we are noticing that many applicants age 65 and older are still applying for the program because they are not able to afford Medicare eligibility. And so in order to be able to serve those patients, we would like to adjust that language in the statute to replace it with language where we would be the payer of last resort. Ultimately, their Medicare would cover their screening, and then we would pay for anything that's remaining as an out-of-pocket expense. The third and final request has to do with some obsolete language regarding our processes. It specifically indicates that we use vouchers. However, we no longer use vouchers. We do reimburse on an insurance basis. We provide basically an identification card for the patients. That's everything that I have to present on the statute change, and I'll stand for any questions.
Representative Ottman.
Thank you, Madam Chairman. Ms. Jones, just clarification, because you did a wonderful presentation. On the front, where you say we're going to amend the age requirement from 50 to 45, we took the number 50 out of there and are putting meet appropriate age requirements in accordance with national evidence. Is that better terminology than 45?
Ms. Jones?
Madam Chairman, Representative, yes. So the USPSTF reviews guidelines on an average every 5 years. So the colorectal recommendations has actually changed 5 times since 1996. So in order to make it so that the program can align eligibility criteria with whatever future recommendations they propose, we would like to remove age criteria altogether and just have it state that we would follow whatever the national guidelines are.
Okay.
Do you change your rules for that program based on the specific age, or do you not state it in rule even?
Madam Chairman, currently it is stated in rules, so we would need to update the rules if we change statute.
And a follow-up. So when you were saying about the Medicare services, that we would change that to make them eligible, can we adjust what Medicare does and what they don't do? And then the other thing is on the back, it says we will cease payments after. Is that like out of a pool? The pool of money or okay,
Ms.
thank
Jones?
you.
Madam Chairman, Representative, sorry, to clarify, the language that we're proposing for the statute just removes the language that people who are eligible for Medicare aren't eligible for the program. We're not changing anything with what Medicare covers. It just allows us to be able to enroll these patients and cover anything that's remaining. Currently, if they're even at age 65 and presumed to be eligible for Medicare, we cannot enroll them into the screening program. So they would be denied for services, whether or not they had Medicare.
And Madam Chairman, if I may, Representative Ottman, it's, I think the intent of this language and statute historically has been, as we see across many of our programs, if there's another pay source that covers a service like this, we shouldn't be using, state programming like Medicare or Medicaid. We shouldn't be using state programming to provide services in lieu of that. As Starr mentioned, this would allow us to take Medicare enrolled people who still fit the eligibility criteria of the program with their income and assets, et cetera, to be able to cover, co-pays, deductibles, that kind of thing for those services. So it doesn't change the underlying eligibility criteria.
So regarding Representative Ottman's question about page 3, where it says, when the funds appropriated for this program are expended, the department shall cease payments under this section. So that, to my reading, that's not changing what we already do, which is when you're out of money, you're out of money. It's just changing the word voucher to payment. So that was part of that follows along on page 2, line 22, where we're just changing from voucher to services. The fact that when any state program runs out of money, we stop doing it. We still do that. Oh, Representative Hallinan, did you have a question?
Thank you, Madam Chairman. I saw in there that it said that the expenses are limited to the colonoscopy. Does that include the cost of the anesthesiologist and the operating room where these procedures are performed?
Madam Chairman,
Jones?
Representative, yes, the outlined in rules expands upon what is additionally covered. So the surgery center, the anesthesia, and the biopsy or pathology for any polyps that are removed are also covered.
Thank you.
Okay. Any more questions for Ms. Jones?
Madam Chair.
Senator Hutchings.
Thank you very much. Ms. Jones, just a quick question on why this particular procedure, when we're dealing with cancer, is colon cancer like the #1 cancer of all the cancers and issues in people? Or in other words, what made us say as a state, we're going to pay for colonoscopies of all the things to pay for? Thank you.
Ms. Jones.
Madam Chairman, Senator Hutchins, colorectal cancer is always in the top 5 of our causes of death. So I believe it normally goes between #2 and #3, depending on the year, but it is one of the top 5.
Okay.
Follow up?
Oh, follow up, yep.
Oh, gosh, sorry about that. Sometimes I still forget things, what I was gonna say, but let me see if I can look over what I wrote here and bring it back. I can't right now, but when I do, I'll yell at you again. Thank you.
Okay.
It's been a rough summer, Madam Chair.
However, we are glad that you are recovering well, so well from your surgery that she overdid, which is why she's there instead of here. So overdoing is a sign of health, I guess. So we're good with that. Okay, no more questions for Ms. Jones. All right, so is there any public comment on this bill?
Madam Chair, I did remember. Yeah, I did remember. My question was this. We're at the last hour here in our Labor and Health Committee. Why was this draft brought so late? I'm used to having a bill, information brought forward, presented, and then we vote on a bill, whether we want one drafted. And here we have at the last hour, a bill drafted already in front of us. No one voted to have it done, even though it's a minor change. I just want to know why this was brought at the last hour. Thank you.
Ms. Jones?
Madam Chairman, I'll
Director.
answer that. Senator Hutchings, you can lay that blame squarely at my feet. This issue, when the federal recommendations came out in 2021, as Ms. Jones mentioned, this was on my radar. It is just now that I'm bringing it to the committee. Again, noting that it is a relatively modest change and a statute cleanup on some administrative issues. Thought it was doable in this meeting, but Senator Hutchings, that's on the Director of the Department of Health.
Follow up?
Senator Hutchings.
Thank you, Director. And with that, you brought up another question when you said it was a federal recommendation. And my feelings on the federal government's intervention and federal government's entanglement in state issues. If we don't do this, what will be the ramification on the federal side? Thank you.
Madam Chairman, Senator Hutchings, no ramification on the federal side. If this did not go through, ultimately state statute just prevents us from serving that clientele that would have their, a recommendation or ability to receive one of these cancer screenings at a lesser age than age 50. But there's certainly, unless Ms. Jones corrects me, I don't believe there's any federal penalties, for example. And as she mentioned, this is a United States Preventative Task Force that mostly from a clinical perspective makes these recommendations down to states and health systems, health insurance companies, et cetera. So there's no penalty if we don't do this. It's really just our ability to align with the current best practices and align state statute with that.
Madam Chairman?
Senator Baldwin.
Yeah, you did it again.
Because I'm looking at her.
I would just throw in just one quick comment here, just for commentary and whatever you might call it. This is my shameless plug for those who have things that they want heard, perhaps during the next interim, and they need to get those in during the time that we allot for setting up those priorities. I would say to Senator Hutchings, there's at least 4 other bill drafts or ideas from other legislators that I've turned away, being last minute things. And they're all valid ideas. They're all good ideas. They're all good things that probably need to happen. But those ideas need to come before that interim ideas so we can prioritize those. And this would be that plug for all those people thinking about legislation. Please put those in that process and we'll do them the right way and we'll get them done perfect.
Thank you, Senator. Of course, committee, we do because we oversee a number of agencies, it is pretty typical that agency cleanups will kind of come toward the end because they typically are more in the realm of cleanup than new policies. And so they often do fall kind of at the end that's why one reason why our last meeting is traditionally in Cheyenne, because we've got the staff here that they can present on these more cleanup topics and not use their travel budget to go up to some other place. Okay. So there was no public comment. Oh, Representative Hallinan.
Thank you, Madam Chairman. I wonder if you could, if our testimony people could tell us how much the Is it a Medicaid payment for these colonoscopies? And how much is that payment compared to the charge?
Director or Ms. Jones?
Madam Chairman, it's Representative. So on average, the cost for a colorectal cancer screening with the anesthesia and surgery and polyp removal would be less than $1,500. We do reimburse at the Medicaid rate. I am not familiar with what the standard rate is or what the adjustments would be, but that is what we reimburse at.
Thank you.
Certainly cheaper than having your entire bowel resected. Okay. What? Oh, funeral, right. Okay. Any more questions? No public comment? Okay, public comment on the bill is closed. Do I hear a bill is moved by Baldwin? Is there a second? Seconded
I'll
by
second.
Campbell. Is there any discussion on the bill? No. Well, then we'll take roll on the bill.
Madam Chair, this is a roll call vote for 23 LSO 276 Cancer Early Detection Amendments. Senator Furphy,
Aye.
Senator Hutchings,
A reluctant aye.
Senator McEwen,
Aye.
Senator Wasberger excused, Representative
Senator Hutchings, are you trying to talk to us? Okay. Go ahead with the roll, sorry.
Representative Brown,
Aye.
Representative Connolly.
Aye.
Representative Flitner,
Aye.
Representative Hallinan,
Aye.
Representative LeBeau,
Aye.
Representative Ottman, Representative Stivar,
No.
Representative Worf,
Aye.
Co-Chairman Baldwin,
Aye.
Madam Chair Wilson.
Aye.
Madam Chair, we have 12 ayes, 1 no.
Very good. All right, then the last item for this morning is further information from Pear Therapeutics. Hi there, welcome back.
Thank you, chairs of the committee and members. We're very excited to be here again to continue the conversation about our FDA authorized prescription digital therapeutics, or PDTs, that treat substance use disorder and opioid use disorder by deploying evidence-based cognitive and behavioral interventions. Reset, which treats substance use disorder, and Reset-O, that treats opioid use disorder, are currently the only FDA-authorized PDTs that treat the aforementioned dependencies and are currently being used in several states such as Oklahoma, Kentucky, South Carolina, and Ohio. As mentioned during our last hearing, prescription digital therapeutics are software-based disease treatments intended to prevent or treat a disease that are currently regulated by the U.S. Food and Drug Administration. They are not standalone solutions, but are used as complementary tools that support and supplement the treatment provided by a healthcare professional, similar to a prescription drug. As a follow-up from the last hearing, the committee requested both Pear Therapeutics and WAMSAC to meet so that WAMSAC's membership could review and evaluate the clinical efficacy of our PDTs. I will let Andy speak more to the support position, but we had a very productive call. One of the most powerful moments of our meeting was when WAMSAC's psychiatrist mentioned how tools like this could help save lives in Wyoming and help reach patients that otherwise have not previously had access to the type of care offered in our digital therapeutic. We remain excited to work with WAMSAC, the committee, and the governor's office on potential 2023 bill language to appropriate funds so that Wyoming patients who are struggling with a substance use disorder or opioid use disorder can access PDTs via a pilot program. As discussed by the committee a few months ago as well, ARPA dollars were brought up as a potential funding source for this pilot. This would align perfectly to ARPA's expenditure guidelines per SAMHSA's May 2021 memo to all single state authority directors and state mental health commissioners. This is a funding source that other states have similarly used to fund access to PDTs. Given the data reported to the federal government on how many patients were enrolled in outpatient treatment in Wyoming in 2020, we would continue to respectfully request a pilot program for 1,900 prescriptions be created with a total cost of $2.86 million. The prescription amount accounts for a total base pilot of helping 1,520 patients plus 380 additional scripts for refills, as we know recovery is not linear. Refills may also be used as an initial fulfillment of a prescription if need be, and they will never expire even after the pilot.
I'm sorry, tell me how many patients that was again?
1,520.
Okay, and the 2.86 million, was that an annual or a biennial figure?
So that would encompass the entire pilot, which would run for 2.5 years. And that is in alignment with the expenditures for ARPA funds.
Okay.
At the same rate, PAIR would be honored to partner with the state of Wyoming at any scale to help ensure patients get access to these critical behavioral health services. Lastly, given our experience standing up these pilots across the United States and various states, minimal work would be required from the Department of Health to administer the program. PAIR provides all onboarding and training of facilities participating in the pilot, and upon completion of the program, submits a capstone report to the state that highlights the results of the pilot. For example, cost savings to the state, abstinence and retention rates, reduction in healthcare utilization, etc. Thank you, committee members, for allowing PAIR to testify at this hearing again, and we look forward to potentially collaborating with you on bringing PDTs to Wyoming so that patients have the best fighting chance of recovery. Namely, we look forward to identifying additional critical success factors and reporting back to the legislature upon completion of a potential pilot. Thank you.
It's Mr. Mendoza, correct?
Correct.
Okay, questions for Mr. Mendoza?
Madam Chair.
Senator Hutchings.
Thank you. Mr. Mendoza, I'm a little disturbed about this whole process. I feel like I'm a panelist on a popular show called The Shark Tank, where somebody comes up with a potential product or something, and they want people to come in and invest in it. Your product, it seems to me, would be best brought before a group of psychiatrists, mental health providers, doctors at one of their local conventions, instead of bringing this to a state government and asking us to spend state dollars on a personal, private type of project. Can you tell me, I mean, you've mentioned that other states may be getting involved in this, but I do not look at this as a proper role of government to take a project on like this, but I see this as something you should take to the medical community and let them decide if they want to have a pilot program amongst themselves and not get the state or federal government involved. When the federal government is involved and entangled in state issues, there are always strings attached. And I, for one, am not for that. So can you tell me why you're coming to the state with this type of process?
Absolutely.
Mr.
Thank you,
Mendoza?
Senator, for that great question. So right now, because commercial health plans don't robustly cover prescription digital therapeutics, even though they are an FDA authorized treatment, and Medicaid or Medicare does not have a category for reimbursement for a tool like this. States have been putting up funds in the interim so that providers and patients can access this type of treatment modality. To your point, Senator, as a follow-up from the committee's recommendation from the last hearing, we did actually reach out to some of the providers in Wyoming, most notably the WAMSACS providers that provide most of the behavioral health services in the state. And we got quite a bit of great reception there. But as we know, unfortunately, many of these clinics, regardless of where they are at within the United States, have very limited funding to actually purchase not even the tools we're talking about today, but medication, hiring individuals, right, to perform these behavioral health services. And so right now, in the 10 other states we're working with, the 3 Native American nations we're working with, as well as a county in California, they've decided that the most appropriate way to fund access to these tools so that the legislature or the governor's office can really evaluate whether a service like this should be made available indefinitely to patients has been through an appropriation from a state or from a legislature. So that's why we brought this issue before the committee from during the last hearing. But in terms of the efficacy and the excitement around providers that are based in Wyoming, I'll let Andy Somerville talk a little bit about their experience reviewing the clinical efficacy of our applications.
She might be in the hall. I think
Okay.
they're looking for her. And I'll just add on to that. For the committee's thought, we just finished hearing from the Department of Health the big report on the behavioral health redesign and how much money we as a state pay for mental health community mental health services for the uninsured and the criminally justice involved in that category of person. So from my perspective, it's in the state's interest to find a way to actually, through a product like this, actually reduce the amount of expenditure that the state is making. When we just heard that presentation, if we can find some clinical way to assist more people more successfully at a lower cost than what we're paying now for that group of people, that seems to everyone's advantage, really. So that was certainly why I was seeing this as having potential. Ms. Somerville, we found you. Sorry. Just, Ms. Somerville, if you'd like to let us know what your group found.
Thank you, Madam Chairman, and I apologize. It's a busy day here at the Labor Health Committee. Andy Somerville, Executive Director for WAMSAC. So we have spent the time since our last meeting having many meetings with Paratherapeutics, their medical director. They have met with my providers who have gone through the data and the information. And what the providers have reported back to me is that they are interested in this. They think that it has the possibility to make a difference. It's still, they feel like it needs some work on the ground in terms of how we would implement that in Wyoming, particularly in terms of the prescriber access and how we would manage that. We don't think that's an insurmountable hurdle. We just know that prescribers are rare. They're a unicorn in Wyoming sometimes. And so we certainly need to work on that. The other thing that I would report to the committee is that we have started to look for funding for that, and we have not been able to identify a good outside source to provide funding to add this service. We certainly don't want the service to take the place of, say, for example, for our clients, for a substance use client, many of them that are on maybe an injectable medication or something along those lines. We don't want this to supplement that or be in the position of where they can't have their prescription drug medication. We don't want it to be an either or situation, if that makes sense. So we still need to identify some funding that would allow for this to be brought in, but we think it's worthy of a pilot and taking a look at it.
Okay, questions for Ms. Somerville?
Madam
Representative,
Chair.
just a minute, Representative Connolly has a question.
Thank you, Madam Chair, and Ms. Somerville and Mr. Mendoza. I'm not 100% sure what your ask of this committee is right now. Is there a need for a statutory change in order to provide this service? It does sound like there's a need for money. So is there a request, for example, for a letter from this committee or its chairs to the Appropriations Committee for increased funds to the Behavioral Health Division of DOH? I'm not exactly sure what the ask is. Thank you.
Ms. Somerville.
Madam Chairman, Representative Conley, I think that the letter would be the request that we would make right now. In terms of statutory changes, I haven't identified any yet that would need to be made, but the funding is certainly the issue in terms of getting this off the ground. So I think a letter from the committee If you have a particular funding source you'd like to put forward, would be welcome.
To your experience with the ARPA dollars, is this something that would, whether the governor's office thinks or not, but I mean, it fits into the parameters of the ARPA, the remaining ARPA dollars that we have, right?
Madam Chairwoman, yes, it does fit into the parameters. I would also just tell the committee, I did investigate also using the SOAR grant that Wyoming has received. There's one more, we've already allocated this year's funding, that's started already, but there's one more year of funding. The difficulty that I came to in there is that Wyoming receives a base amount of SOAR funding, the 4 million. We had to reduce, Department of Health had to reduce the amount that was going to providers for on-the-ground services because of additional SAMHSA requirements that were put into place that are pretty burdensome. We all love those. And so we're concerned that we don't think that that is going to be a good alternative funding source.
Okay, Senator Hutchings, did you have a question?
Yes, ma'am. And I appreciate the time. Andy, I'm still concerned about the state involvement. For me, my thought would be this group would go to a outside source for funding and then present this to the state and not come to the state. You're asking the people of the state to pay for this process. And again, I just don't believe you can find it anywhere in our constitutions or our statutes that this is the proper role of government to take on a private entity's little program where they have an app on a phone that gives gift cards to people or kudos to people for not using drugs. This is just not the right forum, and I just wanted to make that clear. Thank you.
So if I can just insert, so just to be clear, this is not that kind of an app. This is a new category of a therapeutic that is approved by the FDA. So we would be paying for this therapeutic in the same way that the state pays for someone's anesthesia or someone's, opioid antagonist or whatever you call those, or a pregnant woman's C-section. I mean, it's a medical expense because it's granted a new category, prescription digital therapeutic. These things have only been ongoing for 5-7 years, maybe something like that. But so the reason that we would be considering paying for this is the same reason that we pay for medication or physician services for the other people that we pay healthcare benefits for. That I just want to be clear about that. Representative Connolly.
Thank you, Madam Chair. And I'm inclined to, I've come not 180 degrees, I had to come some from the last presentation, honestly. But to address Senator Hutchings' concerns, know that, first, I don't think in any way that there would be a letter or an appropriation that would go straight to paratherapeutics, for example. There would be an RFP that paratherapeutics could apply for after if it was added to the budget. And that we have done that before when we have decided that as a state that this is a direction that we should go in. And where I'm thinking of, and it's not medical, but we have supported, for example, Climb Wyoming and Father Factor, both programs that have helped facilitate families, economic development, reunification with kids, all of those kinds of things. But that was added to the budget through the appropriations project. And in that case, nonprofits applied to get that funding. I see your company, unlike Shark Tank, right? Unlike Shark Tank would apply. And DOH would be responsible for the selection of that company. I love the idea that you're thinking about it as a pilot project. So I just wanted to add that this is not something new. It's honestly a little outside of the box. It's innovative. Thank you.
Representative Hallinan.
Thank you, Madam Chairman. You say that this is a medical procedure or a medical issue. And I wonder if the states that have enacted this proposal, have their medical societies commented on the effectiveness of this treatment, or do they support it? So with that question, I would ask that of the gentleman who presented this idea.
Mr. Mendoza.
Thank you, Representative. Yes, so in all of the states that we've worked very closely with different medical societies and other providers that have prescribing authority in the state. And what I can tell you is there's been a lot of excitement around prescription digital therapeutics, given that the United States is in an overdose pandemic, and tools like this can treat, for example, methamphetamines, fentanyl usage, which we know synthetic opioids are very ubiquitous across the United States now. And there has been no pilot that has been stood up to date that has not seen all of the prescriptions that have been used not used by the end of the pilot. For example, in Indiana, where a few thousand prescriptions were given out for the pilot, that was done in 3 months. So as you can imagine, there has been really great receptivity from providers in those states. And we've seen, again, a lot of success in terms of abstinence, cost savings to the states that we have worked in today.
So just to flesh out what Mr. Mendoza said there, you note that this is only available by prescription. Okay, so a provider has to have the ability to write a prescription for this. It's not some sort of a gift card thing or something that they give out in their Christmas stocking or whatever. It's a prescription like a medication. That's why it has to go through the FDA's approval. I admit it's very different, and the reason I only became aware of this over the last year because of my work as in my own day job work as a translator. I have a European client that is involved in this, not this particular issue, obviously, but that's why I had a little bit more background on what it is. But remember, it's a prescription product. More questions for Ms. Somerville or Mr. Mendoza? Representative Brown.
Thank you, Madam Chairman. Maybe not as much a question, but there will be a question in here, as much as there is a statement. And I guess the proclivity of this committee to say, hey, we're scared to death of always accepting federal funds and we don't want the federal government to do this. This seems like it's the perfect opportunity for the states, which it seems like many states have already taken this opportunity to take the lead and take the charge on something that is currently not approved at the federal level. That being said, my question actually is there discussions at the federal level of Medicare, Medicaid covering these services in the future? And what are the status of those discussions?
Mr. Mendoza.
Yes, so thank you, Representative. Yeah, there's been, my federal counterparts have been having daily conversations with Medicaid and Medicare on trying to make this a reimbursable service for beneficiaries that need access to this type of treatment. I know Paratherapeutics has been given HCPCS codes and CBT codes that have allowed for something like this to be reimbursable, but there's a couple other steps that have to happen before that whole sort of structure can actually be hitched on the train and can go. There's also a federal bill that's been introduced, the Prescription Digital Therapeutic Act of 2022, that has been introduced. I don't remember the federal senators that have introduced it off the top of my head right now, but it is slowly moving through that process. So there are multiple conversations happening at the federal level to make something like this reimbursable.
Mm-hmm.
I'm just curious, the request from you guys at this point has been a request from this committee, the chairs and the support of this committee, specifically to JAC looking for funding. Do you guys have a ballpark figure of what something like this ultimately is going to be? It's going to be a tough call, right? Because we don't have any basis on which to call here. But do you guys have a request of what you're looking for?
Yeah, so again, using the data that SAMHSA's reported in terms of how many patients are actually in an outpatient treatment sort of setting right now seeking substance use care, and I'm sure Andy can speak to this much better than I can. We use that number as a basis to sort of come up with that 1,900 prescription amount that would run over a 2.5-year pilot. It would look at, again, 1,520 patients, and then make available some additional refills, just because we know recovery is not linear and sometimes patients need an additional prescription to remain abstinent.
Representative.
Yes, thank you, Madam Chairman. Mr. Mendoza, this is very interesting. So this pilot program, okay, because it's not FDA approved, so this is.
Excuse me, it is FDA approved.
It is FDA approved. Okay. Okay, good. So 1,900 prescriptions for 1,520 patients, potential of 380 more would be almost $3 million, correct? Okay.
Correct.
So what I'm wondering, because I'm not familiar with the product itself, what I'm wondering is that, okay, it's for patients 18 years of old and older. We've heard that it could be beneficial because it would eliminate or possibly help prescribers to see more patients or facilitate more actions. But what I'm wondering is, it says that it's not for people whose you have to have English as a primary language, you have to have a reading level of 7th grade and above, and then that it's for 12 weeks, okay? So that would encourage people to come back to their physician. But it's not for people who are dealing with opioids, and that seems to be the main place where we're having trouble. And then also not with people that have alcohol problems. And what I'm wondering is this going to create, with all of these indicators and things that need to be watched, is this going to open up a door for a lot of litigation if the state sponsors it? Thank you.
Thank you.
Mr. Mendoza.
Thank you, Representative and Chairwoman. So take your first question. So our reset tool is specifically for substance use disorder. So that covers stimulants across the board, right? From methamphetamines to alcohol use to cocaine to cannabis usage. But as a part of answering this question, I'll also defer to my colleague Scott to add some of the more clinical background. But Reset O specifically is our other FDA-approved product that is specifically designated for opioid use disorder. So there are two different products. Reset is for stimulant use. That tool is FDA approved. And then Reset O is for opioid use disorder. And that tool is also FDA approved. But in terms of the indications, I'll leave it to Scott to answer some of those questions before answering your second question.
Go ahead. I'm sorry, remind me your last name again? Sheppers?
Yes.
Okay. Good.
All right. So I was just going to comment on the questions regarding the indications. So there are specific indications for the product, which you read off, and Mark added some color that there are two different products which have different indications. So those are part of what happens when we go through the FDA. So based on the clinical trial data that we submit, we receive very specific indications of patients who should use the product, patients who should not use the product, but it really does come down to the discretion of the provider and their prescription practices, really the same way that we see with other prescription drugs. So every prescription drug may not be for every patient, and most of the time that is based on the clinical trial data that's produced. For example, a prescription product may not be approved for pregnant patients because the clinical trial data does not support its effectiveness in those patients. That would just be one example. But
Senator Hutchings, did you have a question? You're muted.
Thank you again. And I did. My question was, I don't know if I just don't see the data that Representative Ottman was looking through. I don't see it on my list, or it was from the package of last time we met. But what I'd like to do is get a list of the states that have approved this type of thing via their legislature, just to maybe have the opportunity to talk to other legislators and see what's going on in their state. So if someone can provide me with that list, or the committee, I would love to have that. Thank you.
Sure, Mr. Mendoza, if you can just send it to LSO and they can share that with us. Thank you. And was that information in the packet from our last meeting in Casper? I don't recall.
No, we did. Yeah, we did not list specific legislators that were champions in other states, but happy to get those names and contact information.
More questions? And I think Representative Connolly's question a little back was a good one, as far as, what is the role here of the committee? And I think one of the things that we have done on the Labor Committee, for some years, is sometimes we are just a forum for information on healthcare topics, whether it was vaccines or people come in because they have a concern about their, some sort of workforce issue or whatever, sometimes we're just here and because we can take testimony and share, and sometimes we tell people, okay, you go back now and do it with somebody else. But we are here in a public way in which people can get information and share it. And so I do think, Senator, because, and of course, we're not the Appropriations Committee, we don't appropriate ARPA dollars or any other things. Then the governor's office can come up with if they want to have we did have that innovation grant some years ago, but there's certainly not this kind of budget in it. So Senator Baldwin, I guess if we want to, and this is all really, if we want to, as a committee, draft a letter to the Appropriations Committee to say, we have heard information about this prescription therapeutic over the course of 2 meetings. It is FDA approved, and they've been working with WAMSAC and with providers. And it seems to us, from the perspective of Labor Committee, that this may be a tool that would enable us to serve the patients that the state is already paying for in a better way at possibly ultimately less expense. Obviously, if it's just a piling on, then we probably wouldn't want to do that. But if it can result in ultimately quicker recovery at less expense, then it's advantageous. I think that might be useful to send to the Appropriations Committee, because from my time on appropriations, you don't usually have very many people on appropriations who know much about healthcare. And and they obviously won't have time to take the time that we have had to hear about the product. That would be, I would be willing to at least let appropriations know that the Labor Committee has heard it and understands what it's about, and we can maybe give them a 1-paragraph summary. Senator Baldwin, I'd be glad to hear your input on that.
You took the words right out of my mouth, Madam Chairman. And in addition to that, I would include a letter to the governor's office as well. They're well aware, Ms. Davis is well aware of what's going on and what we've heard, but I think it's appropriate that we provide those letters and demonstrate our support. Important that we include that they have discussed with WAMSEC and have had that conversation. And then they can make that appropriate decision to appropriate funds from ARPA or what they deal to do. I would also note to the side here, a meeting I was just at, national meeting in Nashville, we did have a chance to discuss paratherapeutics with Massachusetts trial. And I spoke at length with one of their medical department directors and had favorable outcome from that. So I believe that would be an appropriate move for this committee if the committee approves, and send those letters off.
So is there any more public comment on the digital therapeutic issue? So then what I get, Representative Hallinan.
Madam Chairman, I had another question for Mr. Martinez. Who is eligible to write these prescriptions and monitor these patients when they receive them?
Mr. Mendoza?
Thank you, Representative. So a healthcare professional that has prescribing authority within the state of Wyoming would be eligible to prescribe these prescription digital therapeutics to a patient.
Thank you.
So that can range from a physician to a nurse practitioner. There's a whole host of different healthcare professionals.
Okay. All right, I don't see any more questions. So what I would ask is that if I would ask the committee to just indicate by show of hands if you would be in favor of Senator Baldwin and I sending a letter to appropriations to sort of summarize briefly what we have learned so that they might have the wisdom, our wisdom, when they consult with each other. If you would be in favor of that, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. Okay. All right. I'll just, for finality, opposed. 1, 2, 3, 4, 5. Okay. Very good. Thank you. Thank you very much. All right. Yes? Oh, I think we've dispatched this issue probably for now. All right, that is the end of, wow. Do I actually see a half hour early? Surely there is. It'll be the last, it may never happen again, so we'll take advantage. All right, so committee, we have next on our advantage, actually this gives us a, you can, do your, go and buy your anniversary card or something on your way. All right, committee, next on our item, we have the 11:45 lunch to tour HealthWorks facility. The reason that this is on here, you know me, as a teacher, I love field trips. So that's HealthWorks is a federally qualified health center. Those of you who've served on the committee, you hear us talk about FQHCs quite a lot. And here we have one in Cheyenne, so you can see that. The other important thing I think about, so two things that I've asked them to talk about to us. One, just to help everybody understand the governance structure, because I think it's important to understand what they do as a community, basically a nonprofit provider. Excuse me. The other component is we often talk about needing to provide services. Here, you tell them what we're doing with the sliding scale. We talk about providing services to low-income people, and how do we do that? Is it always state money? No, it's not. We have community providers, and people pay based on their ability. So I could go and pay full price. A person who is, works at a restaurant, a fast food restaurant, and doesn't maybe make that much, might only pay $5 or whatever for their various services. They basically provide primary care. So I wanted us to have a chance, and there are several others, and we can actually ask Ms. Schickish to just give us a 2-minute summary. There are a number of other FQHCs across the state. Maybe you could just tell us where, come on up and tell us where they are, seeing as we have a whole half hour. That's right. Before I choke. Those of you, so we have a map here, and I know probably Mary Lynn has some too. I would also say, in the way of a bribe, if I can use that word online, I am providing lunch for you at no cost to you out of my own pocket. So please come and eat the lunch that I'm paying for. No state or federal money involved. Representative Stivar. I think it was Qdoba. Was that it?
Yes, Madam
Water?
Chairman, it is Qdoba.
Oh, thank you. Qdoba.
And
Okay.
the food has arrived. Tracy just sent me a text. So
Oh,
if
good.
anyone's
Very good.
hungry, it's,
Okay.
and I'd also be happy to drive anybody out. It's out on the south side of town, and it's very easily identifiable if you go straight over the viaduct and take a left on Fox Farm
The
Road.
maps are here. Okay, just summarize very,
So,
like,
thank you very much.
where the other ones are
Yes.
located.
So the federally qualified health center, the health centers are spread throughout the state of Wyoming. Here in Cheyenne is HealthWork, which we'll see. And similar to that is the Healthcare for the Homeless program here in Cheyenne. And as we move north in the state, there is a health center in Casper, which also has satellites in Riverton, Lander, and in Du Bois. There is a site that is in Powell that has been expanding to Lovell and is moving south to Sheridan. They're growing in numbers around the state, and they're very much what Sue has described, Senator or Chairman has described, apologize for that, is really they operate on a sliding fee scale. So if someone walks in the door and has an inability to pay, they do allow them to receive the services free. And they serve as a very solid resource for individuals throughout our state who have many who lack health insurance. So you'll see it's a full broad array of services. In order to qualify, they get minimal amount of federal funding, but in order to qualify, they provide a variety of services, all the sorts of outpatient services that you get by going to your own doctor, but also behavioral health. So they have counselors on board. And in a handful of them throughout the state, in Casper, here in Cheyenne, you'll see, and in Powell, they provide dental service as well. And you know, for individuals, that can be very difficult. So it's a valuable service that the health centers provide. In Wyoming, compared to other states in the country, we're a very young program. Many of these have been existing for years and years throughout the US. They're very broad and expansive, and they're community health center services. So you and I can also receive those services, and they're paid for by insurance. So they're really a valuable service, and I think they will all enjoy the opportunity to be out there today, and really appreciate you taking the time to come. And like I said, I'm happy to give Representative Ottman and others who'd like a ride out. I cleaned out the back of my car so people will fit in.
And just to confirm, all of these community health centers have community boards. People from the community are on the board of directors, isn't that correct?
That's a very important point. So in order to receive the federal funding, half of the recipients have to be, or the board members have to be made up of people who receive those services. And though he's left the room here in Cheyenne, Josh Hannes is the current chairman of the board of the center here in Cheyenne. So it has a handful of healthcare type folks on it, as well as local folks. And they meet monthly, and they govern the activities of the organization.
So we are recessed for lunch, and according to the agenda, we will be back at 2 o'clock to hear about funerals.